Hello, I'm Locke Meredith, and I'd like to invite you to join me on the next Legal Lines, where my guest is Dr. John Clark. He's a board-certified physician of physical medicine and rehabilitation, was educated and trained at the famous Mayo Clinic. Dr. Clark's going to talk to us about the type of injuries he treats: brain, spine, joint, and other types of injuries, how he diagnoses the injuries, how he treats them, and whether it's conservative physical therapy medicines, whether it's invasive shots, injections, or whether it'll require surgery. So join us on the next Legal Lines with Dr. John Clark. Hi, I'm Locke Meredith, and I'd like to thank you on behalf of myself, Sean Fagan, Corey Ogeron, and our entire staff for being our Legal Lines audience for almost 15 years. Our audience now is over 500,000 households. I'd also like to thank Cox Channel 4 and my friend Eric Coleman for being with me from the beginning. From all of us, thank you. Welcome to Legal Lines. I'm Locke Meredith, and I'm very pleased to have on the show today Dr. John Clark. Dr. Clark is board certified in physical medicine and rehabilitation.
Yes,
John,
sir.
it's great to see you.
You bet.
Let's kind of educate the folks on your background real good, because frankly, it's impressive. Tell the folks a little bit about your educational background.
Sure. Well, I got my undergraduate degree at University of North Carolina at Chapel Hill. Spent 6 years in the Navy. When I left the Navy as a naval officer, I went to the Wake Forest University in Winston-Salem, North Carolina, and got my MD degree. And then I went to the Mayo Clinic in Rochester, Minnesota, and got my 4 years of specialty training in physical medicine and rehabilitation.
And that's the famous Mayo Clinic.
Yes, sir.
Impressive. Also impressive is the fact that you served in our military, and I want to personally thank you on behalf of myself and everybody else who watches this show, because you guys make a lot of sacrifice. I also saw that you actually served on a ship.
Yeah, I spent 3 years on board a ship as a naval officer. It was in the Western Pacific. It was an interesting experience.
and then taught there also.
Yes, I taught RLTC at University of Minnesota for 4 years.
And in reviewing kind of your expertise, I saw that you've also taught at the LSU universities.
Yes, I'm faculty at the LSU.
And then you've been a medical director in numerous hospitals here on behalf of Our Lady of the Lake, the Medical Center of Baton Rouge, Ochsner, about near every hospital that I've seen around here.
Right. Probably the main one was the Continental Rehab Hospital, freestanding hospital on Essen Lane.
And currently, as I understand it, in private practice.
Right, I'm currently in private practice.
I wanted to do a show with you, John. You know, I was thinking we go back, way back to a very serious and very sad brain injury case, and that's where I first met you. But, you know, I thought it would be appropriate for folks to understand how a doctor goes about treating someone who's injured. And so I wanted to talk to you initially. You know, you're presented with a client who's injured. Let's kind of talk about it in the context of the brain, the spine, and maybe the joints and soft tissues.
Sure.
So what does a doctor need to diagnose an injury?
Well, actually, the most important thing is a history. Talk to the patient, have the patient tell you their story, tell you what their problems are, what makes a problem, how long they've had it, what was the onset, how long has it been there, what makes it better, what makes it worse.
And my recall is that the mechanics of how, because it's not like every accident, your only clients are accident related. I mean, you have folks with strokes or folks who suffer any kinds of a disability.
Right. We see patients with joint pains, Parkinson's disease, multiple sclerosis, back pain, neck pain, limb pain, joint pain. Anything that causes a functional impairment or pain is something that we treat.
And so the first thing you need is how did this happen, and give me your symptoms and what are the ongoing problems from this injury.
That's correct.
Okay. And so I guess if there's an injury from a traumatic event, meaning like a car wreck or you fall off your back deck or something, maybe the mechanics of how it occurred?
Right. A great example is a car accident. If you have somebody has a car accident, they get rear-ended, you want to know that their head hit the windshield or a window. Do they have any kind of head trauma? You want to know where they're hurting. Did they have a neck rest? Were they wearing a seatbelt? What was the speed of the impact? How much damage to the car? How long ago did it happen? Were you taken to the hospital? Those are all details that kind of give you an idea of severity of the impact, which leads to other questions like, was there enough of an impact that there could be possibly a fracture? Or are we dealing with soft tissue injury? So after you do your history, you follow that up with an exam.
Okay.
And then based on your exam findings, you will order some diagnostic tests.
All right, let's talk about the exam that's done. And this typically is done on the first visit?
Yes. After you take your history, you do an examination.
All right. And when you do the exam, I guess the type of exam that you do depends on the injury. If it's a brain injury, there's certain kinds of, I guess, things you're looking for versus a spinal injury if you suspect that's the case.
Right. Well, you're checking for both, if there's a history of head trauma. And for a brain injury check, it's not only a neurologic examination, but it's also questions about executive function.
Define for the folks what a neurologic
that would be where you're
is,
testing
what we're
reflexes, sensation, strength, coordination, fine motor coordination of the hands, balance, gait. You're looking for, make sure neurologically they move and control their
maybe
body.
double vision.
That's cranial nerves. Vision, taste, sound, hearing, all those things we're looking for any abnormalities in those areas. For brain injury, we're looking more for executive function. Do you have memory problems? Is there a personality change? Do you have a hard time sleeping? Those are things we look for. Dizziness.
Fascinating. I frankly was reading some of the old depositions, and you keyed in on the fact that somebody was sweating.
Right.
As being potentially caused by the brain injury.
Right. You can have an autonomic disturbance from the brain injury. That can be blood pressure changes. It can be increased sweating. It can be erectile dysfunction if it's a male. There's all kinds of even pupillary changes, dilation.
And so if that's what you're looking for the brain injury, what are other symptoms that maybe you're looking for as it relates to a spinal injury?
For spinal injuries, I'm looking to see if where their pain is located. Is all the pain axial? By that I mean, is it just in the neck, along the spine, going down the thoracic spine into the low back, or is it going into the arms and legs? If you have pain going or numbness going into the arms and legs, then you know you're dealing probably with some type of neural irritation in the spinal column, referring symptoms into the arms or the legs. So then you start thinking about a spinal cord problem, either be a disc herniation or it could be some type of fracture you want to rule out. So I'm looking for any kind of long tracks, what we call long track signs, where there's things going into the limbs that could be coming from the spine.
Now, what about a joint injury or a soft tissue injury? What type of exam?
For soft tissue injuries, we kind of go worst case scenario to best case scenario.
Okay. So you're ruling out those things
right,
first.
and then you get left with, is there a joint problem? And for joints, every joint's got ligaments that surround it. So you check to make sure the ligaments are intact and providing stability to the joint. You check for joint swelling. You check for joint tenderness. And then you look for soft tissues around the joints and the body structure to see if there's pain or spasm in the soft tissues.
Okay, so that makes up your initial visit, and based on those findings, the history, and perhaps the mechanics of the injury, you may order some testing.
Right.
All right. So let's start with a brain injury. What type of testing, if you suspect there may be a brain injury, do you order?
Again, it depends on how acute it is. If it's a fresh injury, then I would order either a CT scan or MRI scan, depending on the age of the injury, to make sure there's no intracranial process going on, like a bleed.
Meaning they're still bleeding,
right.
Or they've got swelling.
Correct, or pressure on the brain. A lot of times when you try traumatic brain injuries, though, you have shear injuries to the brain, so the MRI scans are completely normal. CT scans are normal, so you don't see the abnormality on these scans. So in those cases, the diagnostic study that you use is neuropsychologic testing. You send them to a neuropsychologist and have them do a battery of tests to try to identify what kind of deficits they have in their thinking and processing.
Very interesting. All right, we'll continue this on the next segment. This is Locke Meredith with Dr. John Clark. We'll be right back. Hi, I'm Locke Meredith, and I'd like to thank you on behalf of myself, Sean Fagan, Corey Ogeron, and our entire staff for being our Legal Lines audience for almost 15 years. Our audience now is over 500,000 households. I'd also like to thank Cox Channel 4 and my friend Eric Coleman for being with me from the beginning. From all of us, thank you. Welcome back to Legal Lines. I'm Locke Meredith, and again, very pleased to have on the show today Dr. John Clark. He's a board-certified physician in physical medicine and rehabilitation. John, let's dive right back where we were. We were talking about initially you'll do an examination after getting a history of what the symptoms are and how, if an accident occurred, how it occurred. And then you'll do an examination depending on what is the possible injury. And then you were talking about the type of testing that we were going to do if you determine that you're concerned it's a brain injury. You talked about neuropsych testing.
Right.
What else? What happens in the neuropsych testing?
The neuropsychological testing is done by a neuropsychologist. It's formalized tests that they do after a verbal interview. They do tests for memory, tests for motor coordination, fine motor coordination, tests for cognitive functioning, arithmetic, reading, all your basic grade school skills that we all go through to see if there's any deficits. And by where the deficits are in the testing, they can determine what part of the brain may be damaged.
And when you say deficits, what you're saying is that it's not properly functioning. They
Right.
should be able to add 2 + 2 or
Right.
perform a simple calculation
Right.
or read a sentence and be able to restate it.
Right, and have memory, have recall.
Right, they'll have to say, identify the last 10 things of the 20 things you looked at.
Exactly.
Okay, and as I understand that process too, they'll actually interview oftentimes family members to see if there's a personality change.
Right, it's very important to interview a family member in a suspected head injury case, because when there's significant head injuries, there will be a personality change, there will be emotional tone changes, there'll be a sleep disturbance. It won't be the same person, and it can be very subtle. But somebody that lives with them will notice it. Even work colleagues may notice it, but you and I meeting them for the first time wouldn't.
And I know in very serious, brain injuries, there's also almost an inability to act appropriately.
Right. They can have called disinhibition from a frontal lobe injury, where they no longer can control their basic drives, and therefore they can be inappropriate socially.
Can blurt out or interrupt or become
Exactly.
angry, moody, all of those types of
I
things.
mean, most people can pick out a severe head injury because they actually have motor problems too, and they just they're not right from a physical standpoint. But mild head injury, which is the most common kind of head injury we have from car accidents or from minor trauma.
NFL football players these
Football
days.
is a great example. Concussions. They don't have, you can see them, you can talk to them, they seem normal, but what they do is they do pre-game testing or pre-season testing for a baseline. So if they have a concussion, they do follow-up tests to see if they're just as good as they were before the season started. If they're not, they know they've got a mild brain injury, and they have to have those tests be normalized before they let them get back into contact.
All right, so the neuropsychological testing is done. Any other testing that you might have done if you are concerned there's a brain injury?
If you worry about seizures, of course you do an EEG. But
Which is testing the electricity transfer.
in the brain, and make sure there's no discharges there that go on spontaneously that can produce fainting spells or abnormal motions that they have no control of.
Now you mentioned that there could be MRIs, maybe CT, and it might possibly identify a bleed in the brain.
Yeah, the MRIs and CTs are actually looking for an architectural change in the brain. There's other scans, brain scans, that we utilize sometimes look for brain physiology to see if there's any abnormal metabolism in the brain. And of course, it's a brand new frontier right now with dementias, with Alzheimer's. They have these new functional MRIs we're getting that can actually study the brain from a physiologic standpoint that shows physiologic changes. And I think those are going to be big breakthroughs in the next 20 years on brain injury.
Speak a little more layman's terms for me in that context. When you talk about physiologic changes, what are we talking about? An MRI in that context?
Well, an MRI in that context, again, the MRI shows you the architecture, but these functional brain scans show you how the brain actually works. A great analogy is you look at a house, you can't tell whether the power's on or off by looking at it from the outside in the daytime, but a functional MRI actually looks at a house. How is electricity working? Are the circuits connected? Do the lights turn on when you hit a switch? And you can see that when the lights are on at nighttime. Well, a functional analysis just kind of gives you a nighttime view of the brain It's how it should be functioning and whether it's functioning normally or not.
Fascinating. It's just amazing the technology that is happening in the world today. Let's shift gears a little bit. If you suspect that there's an injury to the spine, what testing is done?
If you suspect there's an injury to the spine, first of all, it's more than likely going to show up on your examination if it's severe. If it's not severe, it's just simply pain or sensor disturbance, you're getting an MRI scan to see exactly that it's not coming from a disc herniation or a fracture dislocation or some type of other pathology that could be present. So MRI scans, CT scans, X-rays are kind of the bread and butter of identifying what I call musculoskeletal injuries of the spine or even of the limbs.
All right. And there's also scans that are actually done with a certain type of dyes or injected fluids. Explain that to folks.
Sometimes we actually do two types of, we do what we call a myelogram, where you inject a dye into the spine or a dye into a joint space to see if there's any rips in the capsule that surrounds the joint, or if there's any filling defect in the spine, in the spinal column from an extrinsic mechanical compression. So those are typical dye tests we do. We also do what we call bone scans, where you inject a radioactive agent into the bloodstream and then watch to see if it lights up any part of the musculoskeletal system, see if there's a stress fracture that you otherwise wouldn't see in plain X-ray.
What is your, or do you use the thermogram that has been used?
I personally don't use thermograms that much, but thermograms are useful for soft tissue pain because they show where the soft tissues are hotter than the areas are colder. If where areas are heating up, that means it's inflammation.
Now, what about discograms?
Well, we do discograms in patients we're not sure if they're having pain coming from inside a disc or not. So a discogram is basically loading and pressurizing a disc space to see if it reproduces the pain they're complaining about.
And John, I know you've got some models. If you don't mind, would you kind of show the folks using the spine model what we're talking about when you're looking for a particular, say a disc injury in this particular case?
Yeah, this is a spine model. This is the low back, the lumbar spine. And this little red object here is actually supposed to represent a disc herniation. And you can see you've got a vertebral body, and between each vertebral body you've got a disc, which is like a shock absorbing sponge in between the vertebral bodies. And when these discs herniate, extrude through the capsule that contains the disc, you'll get compression on a nerve root like we have right here. I'll just point to it with my little needle right here. So that would be a disc herniation hitting this nerve root right here as it comes out of the spine. And that would be exemplified by pain radiating down the leg. So
the pain generator there is the disc hitting the nerve, it's not hitting the spinal cord.
That's correct. It's hitting the nerve root, not the spinal cord. And you know, one of the treatments we do for when you have a pain like a disc herniation is we do injections, epidural steroid injections. We do physical therapy. And so there's two ways to do an epidural. You can go from the side door here where you put the needle right there in the foramen, which is the hole the nerve comes out of, or you go midline and put it in the interlaminar, we call the interlaminar space between the vertebral bodies into the epidural space there. So you have two ways to approach a disc herniation hitting a nerve.
Is there a preferable way?
I usually go midline with the first shot because it's less painful. When you have a nerve root that's been inflamed, it's quite painful when you put it through the foramen on the side where the nerve comes out.
All right, and the purpose of the test is both hopefully to help alleviate the pain, but also potentially diagnostic. So we'll discuss this on the next segment. This is Locke Meredith, Dr. John Clark. We'll be right back. Hi, I'm Locke Meredith, and I'd like to thank you on behalf of myself, Sean Fagan, Corey Ogeron, and our entire staff for being our Legal Lines audience for almost 15 years. Our audience now is over 500,000 households. I'd also like to thank Cox Channel 4 and my friend Eric Coleman for being with me from the beginning. From all of us, thank you. Welcome back to Legal Lines. I'm Locke Meredith. Again, very pleased to have on the show Dr. John Clark. He's board certified in physical medicine and rehab. And let's dive right back in it, John.
Okay.
You were showing on the model that if there's an injury in the spinal column that is because of a disc that has been damaged, that
right.
One of the diagnostic tools may be an ESI, epidural steroid injection, because it does what?
Well, it's both diagnostic and therapeutic. And MRI will show you there's a disc there hitting a nerve root. And then if you do the epidural, and we use two medications when we do epidurals. One is a steroid, and one's lidocaine, a numbing agent, an anesthetic agent. So if it's actually coming from the disc that you see in the MRI scan, you should have at least a couple hours relief immediately from the injection.
Because you're numbing it.
Exactly, you're numbing it. Now, if you do the injection, the leg pain stays the same, odds are that is not the disc causing the pain into the leg you're concerned about.
So you start looking elsewhere. You've ruled that out as possibly the generator of the pain.
Right, so basically an epidural is both a treatment, but it's diagnostic. It confirms your diagnosis.
Now, if instead the disc is hitting the spinal cord and not a nerve root leaving the spinal cord, same treatment?
It could be. It depends on how severe it is. When you above L2, you have 5 lumbar vertebral bodies. When you get above L2, you have a spinal cord. Below L2, it's this individual nerve fibers called
like a horse's tail.
Like a horse's tail going out into the lower legs. When you hit the spinal cord, though, you get spinal cord compression, and we call it in medical terms we call that a myelopathy. In that situation, you can get gait disturbances where you can't walk. You get bilateral leg weakness. You get bilateral leg numbness. You get neurogenic bile and bladder where you have difficulty peeing or going to the bathroom.
Bladder and bowel control problems.
Exactly. Lose motor coordination in your distal legs. And so that means if it's severe, you're likely not going to be dead in an epidural. You're likely going to be sent to a surgeon to get that disc taken out so your spinal cord becomes decompressed.
And the longer an impingement occurs on the nerve root or the cord without some type of intervention, there can possibly be permanent damage to the nerve root and or the cord?
Yes. Once you start developing a weakness in a limb or an extremity, there's no guarantee that when you decompress the nerve root or the spinal cord that you're going to have motor recovery.
And when you say decompress, we're talking about removing that pressure on
off the disc. There's no guarantee you're going to have motor return or pain go away. In most cases, the pain will go away, but not in all cases. And in most cases, you do get some strength back, but may not be complete. And the upper extremities, the motor recovery is not as good as it is in the legs.
And you know, you had the spine model, and in that particular model, the disc injury was in the lower lumbar spine, and therefore the symptoms were going to go down, as I recall, it was the right side, so it would be right leg symptoms likely.
That's
but
correct.
If it's up in the neck, what's going to happen? Where are the symptoms going to be?
If it's in your neck, it can have symptoms going into your arms, and you can have symptoms if it's a central cord syndrome where you're getting a myelopathy from a disc hitting the cord midline, and you can get gait problems, bowel and bladder problems, all the way down to your legs.
Which some of them might go, this must be in a lower spine, but instead it's in their neck.
Right, it can be in the neck, presenting like it's a low back problem. And in thoracic spine, same way. In thoracic spine, you can have a thoracic disc, you MRI the low back, you don't see any problem, but the problem's higher up. You may have missed it if you don't think about looking at the thoracic spine. And I've seen that happen in a few cases where they got delayed diagnosis because people forgot about the thoracic spine.
Let's talk about, because we've kind of moved in that direction, the various forms of treatment. First of all, let's talk about a brain injury. How do you treat a brain injury?
How you treat a brain injury, first of all, it's going to be over a course of a long period of time. We're not talking about treatment of a few weeks. This is going to be a lifelong changing event for this patient. So you've got to design a treatment plan that's going to go over a period of months and years in some cases. And so first of all, you've got to put them in an environment where they're not being overtaxed. People with brain injuries don't like to be in crowded, loud rooms with a lot of input. They can't handle all that kind of input.
Sensory input.
Exactly. It confuses them. They're not comfortable there. So you put them in a structured environment at home and wherever they go for treatment. And it involves occupational therapy, psychology, social work. It's a team effort to rehab these individuals, and they have to be patient with them because recovery is slow.
And in fact, as I've understood it, you may not even know the extent of a brain injury until 2 or 3 years later.
Most recovery occurs in the first year. After that, recovery still occurs, but at a slower rate. But you have a pretty good idea of where they're going to probably level off at after 1 year.
And the bottom line is for the most part, there's really nothing you can do to improve the brain injury. You're retraining the person?
That's right. You're basically educating the patient on what his deficits are, teaching him how to get around those deficits, and family members. It's not just treating the patient, you're treating a whole family with a brain injury. So you're really educating and training everybody how to maximize their functional abilities with the given impairments the patient has.
So the bottom line is a brain injury after 2 or 3 years is whatever you see is what you're going to get, but now there's a matter of retraining and teaching the person to deal with it and the
Right.
family.
Exactly.
Let's shift gears on the spinal injury. So what are the various forms of treatment? You know, you hear folks talk about conservative care, minimally invasive care, and then surgery.
Right. Well, everybody, all the literature says start out with the most conservative things first.
So what does that mean?
And that
Conservative
means,
care.
That means it's going to be medications, it's going to be, and that could be muscle relaxants, anti-inflammatories, pain medications as needed, physical therapy, activity avoidance, avoid the activities that aggravate your pain. So you modify your lifestyle while you're trying to recover. If that fails, then you look at injections,
Which is
epidurals,
what you were talking
which is
about.
what we talked about. If that fails, then you're looking at possible surgical intervention where they actually have back surgery. Back surgery helps limb pain, like arm pain and leg pain, doesn't help back pain.
So let's talk about an injury to the disc because, you know, there's what's been described in literature as discogenic pain where you don't have a protrusion or the disc itself hitting a nerve or hitting the spinal cord, but there's still pain. What is that?
Well, that is the disc is surrounded by a capsule which has got nerve fibers to it. And it can that capsule can itself get inflamed and cause pain. That's what we mean by disc pain. Because the disc itself doesn't have nerve fibers inside it. But it's kind of like the balloon. The rubber balloon has got sensations to it, but the air in the balloon has none.
Right.
Well, if that balloon hurts, then what you've got to do is try to take the inflammation out of that balloon. So sometimes we do epidurals, sometimes we do actual intradiscal steroid shots to calm the disc down.
Meaning you're going inside the disc.
Inside the disc.
And I guess in a way trying to get the medication to come in from the inside out.
Right.
All right. And the type of surgeries that are done where you've got a disc that's literally hitting the spinal cord or hitting the nerve root so bad that they just can't live with the pain anymore and all the other type of care hadn't worked. Describe that for the folks.
Well, then they're going in, they're going to remove the piece of disc that's hitting the nerve root. And if the disc is large enough to where they feel that vertebral level segment's going to be unstable, they're going to fuse it.
All right, and the fusion, what exactly is that?
That's where they take hardware.
We're talking about metal plates and screws.
Yeah, plates and screws, and they secure the segment they want to stabilize with plates and screws. And oftentimes they'll fill a bone or in the interim so that it actually over time solidifies itself to a solid bony unit.
And so you remove the problem pain generating cause, but now you've got less mobility in the area.
Right.
All right, John, thank you so much. It's been wonderful to have you on the show. Very much appreciate it. This is Locke Meredith, Legal Lines, and our guest, Dr. John Clark. Thank you for being with us.